Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to discuss muscles of the leg, a very important topic, muscles of leg. But basically I am going to discuss two important concepts. One, that of the Gower'S sign, second, that of the foot drop. Gower'S sign. Gower'S sign implies weakness of the proximal muscles of the leg. It implies weakness of the proximal muscles of the legs, especially the gluteus. It is seen in muscular dystrophies. Example, Duchenne muscular dystrophy. Since the proximal muscles are affected, they cannot get up from squatting to standing position in an easy manner. They have to climb on themselves and then get up. Because of the weakness of the extensors, they cannot get up from the squatting to the standing position, because of the weakness of the proximal muscles of the lower limb. So persons having muscular dystrophy like Duchenne's muscular dystrophy, they put their hands on the floor and then put their hands on their knee and then they start climbing up on themselves. This is Gower'S sign. So patient places his hands on the knees as the patient slowly climbs on his body. If we see that kind of a sign, we call that as Gower'S sign, that indicates and implies that the proximal muscles of the lower limbs are weak. It is seen in Duchenne muscular dystrophy due to the absence of dystrophin. Duchenne's muscular dystrophy is X-linked and therefore we see it in boys. Because boys have XY and therefore if one X gets affected, they develop disease. Girls generally escape this disease because they have two X and therefore one X can compensate for the other diseased X. How do we diagnose? The creatine phosphokinase gets increased. They have also the equinovarus foot due to the contraction of the gastrocnemius and soleus. So they have developed contractures. They have pseudo hypertrophy of the calf and slowly it becomes worsened. It's a progressive disease. Nothing much can be done. We may try steroids, but nothing much can be done and muscle is slowly replaced by the fat and the fibrous tissue. What we need to understand is that if a child tries to climb on itself and then tries to get up, it indicates that the proximal muscles are weak, and this is Gower'S sign, highly suggestive of proximal muscle weakness, especially muscular dystrophies like Duchenne muscular dystrophy. So I spoke about the proximal muscle weakness giving rise to Gower'S sign. Now let me talk about the distal muscle weakness, that is the foot drop. So the foot is normally straight, but if the dorsiflexors of the foot are weak, there's a foot drop. Basically, four movements occur at the ankle joint: dorsiflexion, plantar flexion, inversion and eversion. Dorsiflexion, plantar flexion, inversion and eversion. If the dorsiflexors are weak, patient cannot walk on the heels. If the dorsiflexors are weak, the foot has to dorsiflex. If it is weak, they cannot walk on the heels. If my dorsiflexors are good, I can walk on the heels. So dorsiflexor weakness suggests L5 root involvement. If the plantar flexors are weak, then they cannot walk on the toes. If plantar flexors are weak, they can't walk on the toes. It suggests S1 involvement. Then we have inverters and everters. Everters supplied by peroneus, inverters by L1, L5 and the tibial nerve. These inverters and everters are especially useful when we walk on rough surfaces, uneven surfaces, terrain. So when it is unequal, we need this inversion and eversion of the foot. Otherwise, the foot will find it difficult and we can develop sprains and various disorders of the ankle joint. So especially when we walk on the uneven surfaces, we need these inverters and everters. So Mother Nature has been very kind in giving us the inverters and everters, especially they are useful when we walk on uneven surfaces, rough surfaces or terrain. So this is about dorsiflexors, plantar flexors, inverters and everters. So when the dorsiflexors are weak, we call that as foot drop. The foot drop, there are few causes. One, the peroneal neuropathy. Second, the L5 radiculopathy. Third, the diabetic neuropathy. Fourth, ALS, amyotrophic lateral sclerosis. And then finally we have myotonic dystrophy, which affects the distal muscles. The sciatic nerve divides into the peroneal nerve and the tibial nerve. Peroneal nerve divides into deep branch and the superficial branch. Deep branch, the sensory supply is between the big toe and the second toe, the web space. So the deep branch of the peroneal nerve supplies the web space, the sensations between the big toe and the second toe. And it is primarily responsible for the dorsiflexors and extensor hallucis. And therefore, if the deep peroneal nerve gets affected, dorsiflexors cannot be done and there will be foot drop. We have also the superficial branch which supplies the lateral part of the leg and the ankle, other than the sensations which are supplied by the deep peroneal nerve, that is the web between the big toe and the second toe. They supply the everters of the foot. So if there is peroneal neuropathy, especially as it winds around the fibula, especially in women who are put on the lithotomy position for delivery, or compression when they sit with crossed legs on the chest, when there is a compressive neuropathy of the common peroneal nerve as it winds around the fibula, both the dorsiflexors get affected, there is a foot drop, and the everters can get affected. But if there is an L5 radiculopathy, L5 also causes dorsiflexor stimulation, but it also supplies the inverters through the tibial nerve, the posterior tibialis. So very interesting, very important clinical point. There is foot drop. How are we going to differentiate whether it is a peroneal neuropathy or L5 radiculopathy? If there is a foot drop and eversion weakness, it is peroneal neuropathy. But if there is a foot drop but inversion is weak, that means L5 radiculopathy. So we should always examine the inversion of the foot. If the inversion of the foot is also weak along with the foot drop, that means it is L5 radiculopathy. Then the other common causes are the diabetic neuropathy. Why we stress on diabetic neuropathy is that for any peripheral neuropathy, there's a rule of 3 or 1/3 rule or 33% rule. 1/3 of causes of peripheral neuropathy is caused by diabetes, 1/3 is caused by other causes, and 1/3 we do not know the cause, idiopathic. So any person with peripheral neuropathy, we should always consider diabetes. So diabetic peripheral neuropathy is also one of the important causes of foot drop, the others being the amyotrophic lateral sclerosis and myotonic dystrophy. So the clinical significance is that, as I said, if a person has got weakness and has got difficulty on walking on the heels, that means it is L5 involvement. If the person has got weakness on walking the toes, that is plantar flexors are weak, it is S1. And if there is weakness of inverters or everters, they have difficulty in walking on uneven roads or terrain or roads which are rough. Yeah, these are the important clinical points. So when we examine lower limb muscles and when the lower limb muscles are weak, the two important concepts we need to know is one about the proximal muscles, the Gower'S sign, second about the distal muscles, the foot drop. I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.